Good evening, good evening,
Good
good evening,
evening.
and welcome to Couch Conversations. What night is it tonight? It is Monday night, and it is time for Couch Conversations with the doctors. At this time, Joe Harrington is going to take over, and he's going to begin to do those introductions. And we welcome you guys to share, and share again, because tonight is Monday night. Go ahead, Joe.
Thank you, Nikki. And I know you got to drop off for a few minutes, but you'll be back soon. First, I want to thank Congressman Davis and Nikki for setting up this platform, allowing us to share information about health and well-being with the community. And next, I'll ask our guests to introduce themselves. I'm going to start with our newest guest. I'm going to start with Dr. Fitzpatrick. She's joining us tonight, and she can give a brief introduction.
Sure. Good evening, everyone. So I'm Carolyn Fitzpatrick. I'm a family medicine physician and chief medical officer of West Suburban Hospital. Looking forward to talking with everyone this evening.
Thank you. Tessa Anowishki.
Good
Did I get that
evening.
right?
Almost. I am Tessa.
Almost, in the rest of the night, I'll refer to you as Tessa.
it's Tessa. Tessa.
Tessa.
Yes, no
Okay.
worries. President CEO for Loretto Hospital.
How about you, Doug?
So I'm a retired physician. I worked in the western suburbs for 30 years, and after that, joined the congressman in his office. And it was really a very eye-opening experience. I really become interested in public health and public policy. It's really an honor to be here with my colleagues, and we're going to try and answer questions as best we can.
Dr. Mason.
Dr. Terry Mason, happily retired urologist, and spent time both in city and county governments as leadership in public health departments of both the city and the county. And I'm really grateful to be here. And I too send my congratulations and thanks to the Congressman and Nikki for setting up such a great platform.
Yeah, and as I recall, Nikki always introduces you as the urologist to the stars. I know that has some meaning. And what is it, Marilyn McCool and Billy Davis?
Uh-oh.
Yes.
Okay.
Billy Davis was one of your patients.
Yes.
Louis Farrakhan was a patient of yours.
We don't want to go do all that now. So,
Well, I won't go through all that. But Dr. Mason and I have known each other pretty much since he started private practice medicine. Actually, by way of introduction, I've had an interesting career. I've worked in several fields. I did a little work both in mental health and education, but most of my work was in healthcare and public health, more so in public health. I worked at 3 different hospitals. The first was the University of Illinois. Then I went to Mount Sinai, worked at Mount Sinai for several years, had several different positions at Mount Sinai, left Mount Sinai, went to Rush. Worked at Rush for the longest period of time, worked at Rush for 10 years in the Department of Preventive Medicine. Then went back to the health department to serve as an assistant commissioner under Dr. Terry Mason. Left, went to the state health department, became the regional health officer for Cook County for the Illinois Department of Public Health, and retired in 2017 as the regional health officer for Cook County, as well as an administrative law judge. And I'm going to let Caleb introduce himself, although he's not going to be participating. He's sitting in for Congressman Davis, and he can let us know where Congressman Davis is now. He's either in the air or en route by car.
All right, I'm Caleb Gilchrist. I'm the Deputy Chief of Staff for Congressman Davis. At least I'm one of them here in D.C. The Congressman is en route here. I don't know exactly when he's going to arrive, but hopefully very soon.
Thank you, Caleb.
All right.
Yeah, we're picking up on our discussion a couple of weeks ago about the status of safety net hospitals in Illinois, but specifically Cook County. I have a unique relationship with a safety net hospital. I am, in addition to several other things, I'm president of the Roseland Community Medical District, which is in Roseland, and our hospital is, in fact, Roseland Community Hospital, what Tim Egan would refer to as the new Roseland Community Hospital. And it is suffering the same plight as all the safety net hospitals in Illinois. With that, I'm going to turn it over to our illustrious colleagues. I don't know who wants to go first to provide some kind of update as to where things stand and if things have improved or if, in fact, they've gotten worse.
Well, Joe,
So,
if you might,
Well,
if I,
right before we begin that conversation, I want to say hey to Connie Taylor, who is here. She says good evening to everyone. Audrey Jaycox is here, and she says good evening to everyone just as well. Linda Johnson is here, and Linda Johnson is saying good evening. I want to say hey to Alderman Pat Dow, who is also here, and to President Carrie Steele of the Metropolitan Water Reclamation, who is here with us just as well. I want to say hey to all the people over at the Core Center. They are working, but they are in a room making sure that they are being a part of Couch Conversations. They say that this is their ritual on Monday nights to make sure that they aid in breaking disparities by making sure that our community is aware of health care. So I want to say thank you to everyone over at the Core Center. Also want to say hey to Engine 119 of the Chicago Fire Department, who is here with us just as well. They are watching. And we cannot forget to say hello to our group of gentlemen who are in the garage, in the man cave, making sure that they are watching. He invites all his friends over and they watch inside the man cave on Van Buren Street. So I want to say hey to all of them. So Carolyn, if we pointed a question to you that says, what's going on with safety nets hospitals and how do you guys survive? What would your answer be?
So I would say that, with safety net hospitals, and I've worked at, I've been at West Suburban in 2002. I started there first as a resident in family medicine, and was very involved after my residency training in teaching our residents in our residency program before moving on to an administrative role. I did work briefly at Rush Oak Park before coming back to West Suburban as a chief medical officer. And I would say, and I still practice clinically. I do feel overall in medicine, there has been a lot of changes, I would say industry-wide in healthcare, from, having to spend a lot more time meeting the needs of different insurance companies and payers and those sorts of things, that our lives as primary care physicians have become busier and busier. And a lot of those things are not necessarily directly related to seeing the patient in front of you and patient care. There's a lot of additional requirements that are required, from documentation to different approvals and authorizations that insurance companies require us to have. And so I think that we're spending more and more time on the administrative burden of providing healthcare. And unfortunately, that means, less time that we're able to spend direct face to face with our patients. And then of course, everything these days is more expensive. And, all of us see that, when we're going to the grocery stores or that sort of thing. But I would also say things in healthcare are more expensive these days. And it costs more in order to do some of the things that are necessary, some of the basics that are necessary for running a hospital, and also to be able to provide all of the services that we need to. The cost of paying employees and physician salaries and all of those things have gone up over time, and it's really difficult as a safety net hospital, a community hospital, with the resources that we have, in order to afford all of the things that we want and need to provide to our patients.
could I just ask real quick, what is a safety net hospital?
I can answer. A safety net hospital serves a population that is greater than 40% of Medicaid inpatient utilization. They're usually in vulnerable communities that have high comorbidities, and usually in Black and Brown communities.
So why do we make the distinction about them over regular hospitals? What's different? I mean, other than what you just said, what are those challenges, and why is that important for us to deal with and try to accommodate?
Sure. Thank you, Dr. Mason. That's a great question. It has to do with access to care. It is hard for individuals that are on Medicaids oftentimes to get access to care. Safety net hospitals afford individuals the opportunity to receive access to care despite their ability to pay, whether they're uninsured or underinsured. It's critically important because without safety net hospitals, individuals will not be able to, again, access care, the much care that they needed. And so it's very important for safety net hospitals to continue to thrive. And as Dr. Fitzpatrick mentioned, we are at risk of closing. There are numerous safety nets that are at risk of closing, at risk of cutting services, at risk of having the thought to lay off employees, because there have been numerous cuts at the federal level with respect to our directed payments, and we have already struggled with the ability to pay for and cover the cost of care. And so I think this conversation is critically important during this legislative session for the state of Illinois, for the federal government to say without safety nets, the life expectancy rates in our communities continues to decline. And that's unacceptable in this day and age that we are even having a conversation. And so I want to say thank you also to Congressman Davis and Nikki for hosting this platform. But a couple of weeks ago, we had to have a conversation about if safety nets close, morgues are, we become a morgue desert, which is just completely and utterly unacceptable, again, in this day and age when healthcare is a human right.
Yeah, let me pick up on that, and I want to lead into the question. And actually, I want to provide some information that people probably don't think about, is that typically safety net hospitals are the major employers in the neighborhoods where they exist. So they do two things. One, they employ people that live in the community, and two, since these are people that live in the community, it's more likely that they will spend money in the community. So they do provide some return on the investment of having them in the community, because the people that work there, by and large, a lot of them live in the community around the hospital. The other thing to note is that they're in the neighborhood. So for a lot of people, they're in walking distance. You really don't have to go that far. It's a short bus ride, walk, a bike ride, or a cab ride. So you really don't have to go that far. So they're convenient as well. So those are some of the things. But you did talk about the state legislature. And I know that you're waiting for an appropriation. This is budget season, and the state is facing some challenges itself with its budget. But what are you looking to get from the state? Because I think that's what you're hoping to do. You're hoping to get some funding from the state that will allow you to continue to support the work that you're doing.
Thank you, Joe. I know and I know Carolyn knows, is that we've been in constant meetings with the safety and the other safety net CEOs to talk about the need to continue our grant funding. We receive grant funding from the state of Illinois every year, but beginning January 1st of this year, a lot of us took a numerous cut because part of our federal payments was cut. It's a pass-through payment through the state. And so for Loretto Hospital, that was about $9.5 million. If we are unable to fill that gap, that's a loss of about 25% of our services and 25% of our employees. So it's critically important that we find the resources necessary to keep the safety net hospitals open. And you mentioned, Joe, Loretto Hospital contributes over $200 million to the local tax base. Without that, so we're not talking just about healthcare, but we're talking about the local economy will suffer as well.
I just like to piggyback a little bit more on that, because some people think that because I don't pay for it, that it was free. And I think we need to just make sure people understand in a real way why we have these dichotomies potentially in the state system, though we're not trying to beat up on anybody, the federal system, and of course the self-pay, where people try to do the best they can to pay for what they get, particularly medicines.
Carolyn, you want to tackle that? I don't want to take it over.
Sure. Yeah, I mean, again, nothing is for free. There is always somebody footing the bill for something, and either we're paying for it ourselves, or we're paying our dollars through insurance companies to make payments, or we're also contributing towards our state and federal funds in order to cover things for us. So somebody's always paying, somebody's always footing the bill someplace. But I think also in something that Taysa mentioned, and that is in terms of access and what happens if our safety net hospitals that are in our communities are either, God forbid, not there, or not able to provide as much services that we used to. And that means that the access and the wait times for people to get appointments is going to increase. I think we have already started to see, especially shortages in primary care. People have longer wait times in order to get in to see their primary care physician or provider. And those wait times will continue to increase if we are not able to provide all the services that our safety net hospitals provide.
Thank you, Carolyn. I want to touch on I think access to care is just again, it's a necessity. Until we get to universal health care, our safety nets are the ones that provide the care to those that need it most. And so, yes, we do see some self pay, but again, we see a lot that do have insurance, but they're underinsured and can't afford it. The cost of living has increased. So again, it's a necessity and a right for human beings to have access to care. In our communities, the comorbidities are high. For the west side of Chicago, the infant mortality rate is equivalent to that of a third world country. So how do we even talk about not providing care or closing doors or not having a vision to grow so that we can address the needs of the community? And so it's critically important that our legislators really understand the value of safety nets. It does not mean that the care is any less equivalent to those of other prestigious institutions. Loretto Hospital recently received its second A grade in patient safety, which is a testament to our belief that everyone deserves quality patient care.
So is there anything that you can tell us about the number of patients that could be impacted by this,
Oh,
either
sure.
locally or statewide? I'm sure that they put together some briefings to talk about the extent of the problem, what's going to happen, how many people might not be able to have access to healthcare that currently are visiting safety net hospitals.
Sure. So I can speak for Loretto. We see about 33,000 patients a year between our clinics and inpatient. But I think overall, with the Medicaid redeterminations, if there are cuts there, then you're talking about, I believe, 800,000, in excess of 800,000 across the state of Illinois that will lose care. That means individuals will continue to use emergency rooms for primary care services. The wait times increase. When our safety nets do have capacity, and we invite the community and those to be reintroduced to the safety nets, to put their trust and their health in our care, because we do have capacity. And that goes, I know we talked a little bit about it in the last session, is to make the invest your dollars in your community.
The other
So
point,
is,
I'm sorry,
go ahead, Terry.
No,
No.
I was just going to say that we haven't, and having spent some time at county and being involved in patient care and at every single level, from primary care to specialty care, people have to understand just because you don't pay for it directly, don't mean it's free. Somebody somewhere has to pay for it. And that's what this
Mhm.
conversation is about, the ability to pay for it. Not just the staff, the medications, the different diagnostic tools, all the different things that are necessary. All these things have a price tag, and I'm not trying to make it all about money, but it is a lot about money because we've got to make sure medications are even more than they used to be. So
Mhm.
how at the safety net level, if you're trying to manage your budget between what you're going to be able to do on the inpatient side, not versus, but additionally on the outpatient side, how do you manage that? What are the struggles that the issues that you have to think about as you do that?
Oh wow. So I think overall it's cash flow is something that we think about every day. Safety net hospitals, again, because of that designation, we receive on average of 32 cents on the dollar. So when you talk about the average commercial rate that a patient would receive, if you got Blue Cross Blue Shield, you'll likely see 90% reimbursement. For safety nets, we receive 32 cents on the dollar, but our care is not buy one get one free. It is, we do not provide discounted care. We provide the same level of care as other individuals. So there's got to be equity in the reimbursement rates for safety net for us to cover the cost of care. FQHCs received a 2% increase every year for the last 20, 30 years. Safety nets received their first increase in 3 decades last year, but it was reversed because the average wage index in our communities is less. But so we've got to create an equitable formula for reimbursement for safety net hospitals.
So at this point, what are you asking for from the state legislature? Do you have a specific ask? Is there some bill that people could write their local congressman about, or just inquire about and see what's happening? What actions are you taking?
Well, I know from the Illinois Hospital Association is really advocating for an average commercial rate, so that we get reimbursed at the same rate as other commercial insurances, and not just because individuals are on Medicaid. So we would receive 90 cents on the dollar versus 32 cents. So that's at the federal level and the state level. But I think also there needs to be investment in safety nets. We, most of us are probably in 100 plus year old buildings, and we're institutions. But if we had some investment, then we can create models of self sufficiency and self sustainability. For Loretta, one of our asks is investment for our capital infrastructure, and not just brick and mortar, but in equipment that allows us to attract more commercial payers to our institutions. That would help alleviate. So, one, I think all of us could use new medical equipment and technology to again attract commercial insurance, but we still have to maintain our safety net grants until we are able to achieve the average commercial rate as other institutions. So that would be, I don't want to speak on behalf of everyone, but I think we all have a shared goal with respect to getting reimbursed a fair wage, a fair reimbursement, because we're, again, our cost of care is the same. It's the same. It's just the reimbursement we get uh, for those that we serve. And Carolyn, I don't know if you, from West Suburban's perspective.
Sure, yeah, absolutely. I would also add that yes, we provide the same level quality of care, and yes, that care does cost. It's not free, but also I also feel that we also provide a greater amount of kind of social support for our patients. The patients sometimes that we see have greater, social needs, being able to, have to be connected with other agencies that might be able to provide services for them. It takes a lot of extra, sometimes, days on the inpatient, uh, you know, um, and the inpatient stay, which costs the hospital more money in order to make sure that we discharge our patients that have a safe plan in order to go home, have the home care services that they might need. We really do a thorough, kind of assessment of what our patients' needs are when they come into the hospital, so that when they leave us, that not only are we able to make sure that they're in a good environment to make sure that they continue to heal from whatever they were admitted to the hospital for, but also that they're going into, an environment that's going to be supportive for that healing to occur. So, that does take additional time and resources in order to do that as well.
And if I want to add one more thing, and I forgive me, but I think the other thing is we need standardization as far as when we drop a bill or a claim. Different insurances have different processes and requirements in terms of denials, appeals, claim, turnaround time. There needs to be standardization. For safety net hospitals, our resources are smaller, so we can't afford to throw additional bodies to do a job because there's 20 different ways to do the same thing. So I think there needs to be standardization or discussions about standardizations among the insurances for safety net hospitals.
Yes. And, these days also, there are some insurance companies that are using, these AI, artificial intelligence sorts of systems, in order to, deny coverage for inpatient stays. And the hospitals, and we're seeing a greater number of these denials happen. And so the hospitals have to spend additional time and resources in order to prove that the patients that we are admitting to the hospital are sick enough to be considered a full, inpatient admission in order to, get the dollars from the insurance companies and, to provide the care that we need to provide to the patients. And again, that takes additional time and resources to, go through, look at all of these denials from the insurance companies, provide them with additional documentation, information, time on the phone. And again, that takes away from other things that we could and should be doing to care for our patients.
Carolyn, you bring up a good point, because I think another week, and I think I can go. We could
Wow.
probably go on all day. I'm sorry, Nikki. I just want to is our electronic health record. So a lot of the AI
No,
is
go ahead.
built
Go ahead.
into electronic health records, and a lot of institutions are on Epic and Cerna, which is completely unaffordable for safety
Mhm.
net hospitals. It has a lot of those efficiencies and things built into the system, but we cannot afford to get a $20 million system. And that's what most of your larger institutions have.
And I think that it's important that you guys are bringing
So
this out,
we want
because all hospitals are not the same. Just
Correct.
because it's a hospital, it's not the same. You're using the term safety net, but there's a big difference between going to some of the bigger, more popular hospitals and also well endowed hospitals, because a
Mm-hmm.
number of them have people who donate to the hospital. And I'll say this and stop, because a lot of people would say when I was at the county, well, if I didn't pay for it, it was free. Well, no, it wasn't free. You may not have paid for it, but the county levy, the state, and all the other things that help provide resources to agencies like the county and some others like the safety nets that you talked about. That's why these things are important. That's why we're having these conversations, because ain't nothing free. Just because you don't pay for it don't mean it was free. And if you did pay for it, it doesn't mean that what you paid covered the cost. And I'll let the other colleagues talk about this, because when I was at county as a chief medical officer and chief operating officer for at one time, the cost of care and the need that the people had coming through the door was immense, and it outstripped the ability for us to be able to handle that easily. Not to mention that you have to pay livable wages to people, and that's only fair. You have to also do this, get your supplies. Your hat can't work without those. You've got to maintain your plant, and maintaining plants and or needing to upgrade the plant itself. And I think the plant, that's the way the house of the hospital, what building it's in. And I'll let my other colleagues talk about this because I'll get on a well, no,
Yeah.
I learned a lot when I was in the role as chief operating officer for Cook County Health and Hospital System. And when you've got it's a combination of things. It's not just supplies, it's people, resources. It's we have to pay water bills too. We have to pay all these other things like everybody else. We got to pay gas bills. We got to buy the food. We got to do. So I'll stop right there and allow the other persons who are certainly faced with this comment.
Yeah. Well, I'll make.
But definitely want to say hey to Mayor. Want to say hi to Mayor Harvey, who is here with us, and he's saying he's weighing in, saying thank you guys so much for this great information. I guess the hospital that feeds into them is Loyola. That's over in that area. I want to say hi to Jessica, who is here with us, and also want to say hello to DLV Printing, to all of them who are sitting around there making sure that they are here watching Couch Conversations and staying abreast of what's going on. Michelle Garrettson is here. Hey, Michelle, I want to say hey to Audrey Dillon, who is here, and Jackie Underwood is here. Commissioner Donna Miller is here just as well, and she's nodding her head, says, tell the truth, tell the truth. Want to say hey to Marvelous Snipes, who is here with us, and Phyllis Roger, who is here with us just as well. John Nelson says, I have a question. And I'm going to come back and read John Nelson's question in 1 second. Aileen Cox is here. Helen Grace is here. I want to say, hey, Asada Abugala. And Asada, I hope I didn't tear your name up. She is here just as well. Dee Moore is here. I want to say hi to her. Judge David Kelly is here with us just as well. April Prayer is here. Cordelia McClendon is here with us just as well. Sherry Boggs is here. And thank you, Sherry, so very much. And as you guys can hear, the messages are coming in. Tony is here with us. Hey, Tony, thank you so very much. Rochelle Friendly is here with us. Carolyn Ridley is here with us just as well. Well, to John Nelson's question, John says AI is determining whether or not someone is ill and should be in the hospital. Really? AI? Does county have that $20 million system that people are talking about? I want to say hey to Virginia Knight, who is here. She says hello to everyone. Pamela Minguez is here, and she says good evening to everyone just as well. Melinda Maxwell is here, and she says grand evening to everyone. Sister Bonnie is here, and she's saying hello to everyone. And Judge Marianne Jackson is here just as well, and she is saying good evening to all. Well, is AI a good thing? I think that's kind of what Mr. Nelson is asking. And are they making those determinations? But he also asked the question, does the county hospital have that $20 million system? I don't know who can answer that, but don't you all try to answer it at one time. Want to say hey to Deborah over at Coleman's Barbecue. Coleman's is here, and they're saying hello just as well.
So, Nikki, if I can, I'd like to quantify.
I also
so
got a little comment that said the Congress.
Nikki, you went out.
So, Dr. Mason, do we know if the county has that system, or are they operating on that system that makes them privy if a patient is at another hospital?
I can tell you.
Well, first of all, I can't tell you because I don't know what the county has. It's been a while since I've been there, but I do know that we've got to let people know that these things are very, very expensive, and we do need to continue work in the appropriate places to help make certain that the reimbursements for certain insurances and what have you help do a better job in covering. And I'll stop right there.
Well, so Joe, do they have that system? Is that something that's needed?
I don't know, but I can say I'm on the Cook County Health Board. So I don't know if we have that system or if we're using that system, but I do know that analytics, which includes AI, is a big part of healthcare moving forward. And a lot of people are using analytics to make their decisions. And that's what AI does. It takes a lot of data, it condenses and gives people answers to questions. So there's a good side of that, and there potentially is a downside to that. But I think I want to go back because I thought about this. And in our Declaration of Independence and in the preamble to the Constitution, in a sense, it talks about all men, and people say all people are created equal and endowed by their Creator with certain inalienable rights. And among those are life, liberty, and the pursuit of happiness. You cannot pursue happiness if you are not healthy. So that's the bottom line. That's the point that I want to make. We want everybody in this country to have a full and healthy life. Is there's a threat to some part of the system, and the safety net's a part of the system, there's a threat to the system. And I think people need to keep that in mind. Safety nets have been historically an integral part of the healthcare system. If the safety nets don't exist anymore, then that is a threat to the system. My question back to our esteemed colleagues who joined us this evening is, what would you ask individuals to do to help you in your fight? Because we're talking about what the crisis is, but there may be certain things that they as individuals could do to help you. And actually, if they're registered to vote, they're voters. And there are things that they could do to talk to people to help get your argument across.
Yes, thank you, Joe. I think one thing is to reach out to your local elected officials to uh, tell them that it is critical that they support safety net hospitals with the funding necessary to continue to provide services and to continue their operations, as well as, again, additional investments to talk about the need for safety nets to grow with the needs of the community. We learned from COVID that uh, COVID exacerbated the comorbidities in our community. So, but if we can't grow with the need, then again, the disparities just continue to grow. So I think it's important that we reach out to, again, our local elected officials to request that they support safety nets, but to also, again, I'm gonna, plea is to try out your safety nets. I know sometimes we get a bad reputation because we are not, a lot of us are not level one trauma centers. So when individuals come through our doors, their acuity may be very high, or it may be a trauma situation, and the only thing that we can do is stabilize and transfer them to a level trauma. But for your everyday care, your primary and preventive care, we absolutely have the ability and the capacity to accommodate individuals with this, again, excellent patient care. So try your local safety net.
Yeah, I just want to piggyback on that. There are only certain people that need trauma centers,
Mm,
and so if you're looking for primary care, you can get that at a safety net hospital.
mm,
If you have an urgent need that some people might go to some clinic or some pop up, you could go to the emergency room. If you got a cold or a flu, you could show up. They probably wouldn't want you at the emergency room, but they can handle that. There are things they can handle, and there are things that are beyond their capacity to handle. But they are in the community for a certain reason and a certain purpose. And if they disappear, just it's almost like a fairy tale that something all of a sudden disappears, and then everybody said, well, where did it go?
mm.
What happened? It used to be there, and I go there all the time, but what happened? But we're talking about an acute emergency right now that you're facing. And again, if there are other things, if there are letters to be written, I know that some people propose setting up a website to share information. Do you have a website that people look at, or is there information out there that people you could drive people to that could help with this?
Sure. It's savethesafetynets.org is one of the websites that all the safety nets got together and are talking about the importance of the work that we're doing. So we'll highlight each individual hospital. So please visit that website for more information. But again, I think it's really talking to your elected officials, saying the importance of safety net hospitals being available. We obviously we don't want to see you in the emergency room. We want to make sure that you are getting your preventive care and your routine medical care so that we can keep you healthy. That is our ultimate goal. So again, your local elected officials. I think the advocacy has to be beyond just the safety net CEOs talking about the importance of the hospital. It has to be the community saying that we need our hospitals around to provide care for the community.
And if they went to the website that you mentioned, safetynet.org, that was
Save the safety net. .org.
savethesafetynet.org.
Mm-hmm.
So it would list all the safety net hospitals that are facing this crisis. And
Uh,
they could, because they may not even know what the safety net hospital in their neighborhood is. I mean, that's another issue. I mean, how would they know? All they know is there's a hospital down the street, but I don't know if it's a safety net or it's part of a bigger system. So
sure.
there would be a list, and if there's a hospital near them, then they should be advocating for that hospital.
Absolutely, and I know Tim Egan at the CEO of Roseland is maintaining that website, but we'll make sure that all the safety net hospitals are listed throughout the state of Illinois, so that you can see which one is in your community.
You know,
Thank
the
you.
other thing the one thing that I'll also add is that we don't always have to go to a hospital for care. And I think that we need to make sure that there's a better alliance where it's possible between the safety nets and the things like the federally qualified health centers.
Mm-hmm.
The set of federally qualified health centers can do a tremendous job. I just had one on the radio show not that long ago. In fact, this past yes on Sunday, talking about the services that were offered, even down to research opportunities in some of these places. So I think that we need to make certain that we are using all of the resources. I mean, that Congressman Davis was very instrumental in the
Absolutely.
establishment of federally qualified health centers, and they've done a marvelous job and provide a myriad of services. So the linkages between some of the safety net hospitals and federally qualified hospitals would be very important. I don't know what it is, but I do know that there are some opportunities perhaps that could be shared.
Thank you, Dr. Mason. I absolutely agree. And we partner with the FQHCs in our community, hand in hand. So we provide some of the ancillary support that they need. A lot of individuals are waiting 3 to 6 months for a mammogram, a prostate cancer screening exam. You do not have to wait. A lot of us have immediate capacity. In fact, we don't want you to wait, because you know, if you've discovered something, a lump in your breast or something's wrong, you want to get that addressed and checked out immediately. So trust your local safety net.
Yeah, absolutely. I definitely agree with that. And, you know, our services are accessible, they're convenient, they're close to home for a lot of people. You know, to be able to come in and, schedule an appointment very easily to get your mammogram is very important. And encouraging people, to get those yearly screenings done. Um, because yes, we are definitely about preventative health care and keeping our communities as healthy as we could be. That's what part of our mission and our goal is, and so we want to be able to provide that for our communities.
Would you say there needs to be a stronger relationship between some of the safety net or the safety net hospitals and the federally qualified health centers?
I mean, I definitely think it's an important relationship. And, we do want to continue to work with our federally qualified health centers in order to partner and care for our communities.
Absolutely. And I think, in times when resources are scarce, we often resort to competition instead of collaboration for dollars, because everybody's fighting to stay alive. I think the work is equal and that we do need to have stronger collaborations so that we are keeping, again, the patients, the dollars in the community, but making sure that we're making access to care easy for the patients. And so PCC is our local one. And so the CEO and I have you know, made efforts to have a stronger relationship for those patients that are in the need of other or additional ancillary care, surgery, same-day surgery, those kinds of things.
Yeah, yeah. Just a couple of things, and I know we're getting close to time. One is uh, there's there's this thing that's happening called the corporatization of healthcare in America,
Mm-hmm.
and you see systems getting larger and larger and requiring more hospitals, and so that puts a squeeze on safety nets in other hospitals. As these systems grow, it puts a real squeeze on those smaller hospitals that are trying to survive in this environment. The other thing, if you ask who pays for health care, in some respects, we all do.
We do.
Some of us have insurance, but we have copay. So that doesn't mean that insurance is going to cover everything. Insurance will cover many things, but it won't cover everything. So there's still some out of pocket costs if you have insurance. And the major payers are government. I mean, Medicare, Medicaid pay a lot of money comes. So those are your tax dollars that are being used. So it's actually your money that's being reinvested in your community to give you some degree of access to healthcare. So ultimately, we're all paying for healthcare, even
Absolutely.
if it's directly or it's indirectly, and we're all paying for the lack of access and the lack of utilization. If more people use the services and use them the way they should be, we probably have significant increases in life expectancy. We've had some. I mean, one of the fastest growing segments of the American population right now is people over the age of 100.
Mm-hmm. Yeah. Mm-hmm.
That's a testimony to public health and the health care in America. And so we're seeing more and more people live well into their hundreds right now. But there's also the fact that we're seeing a sicker community because sicker citizens because of the foods we eat. And this is something Dr. Mason will talk about, our lack of physical activity and our lack of use of the primary care that's available. One of our esteemed colleagues, Dr. Paul Crawford, always used to say is that our people suffer from what do you call it? Symptom-based paradigm. A symptom-based paradigm. If you don't feel something, then you're healthy.
Mm-hmm.
The worst thing you could do is think you're healthy because you don't have a symptom. Because those symptoms become major over time. A little thing, an ounce of prevention is worth a pound of cure. Getting your annual mammograms can detect cancer in the breast early. A man getting a PSA test can detect cancer early. That means you're much more likely to survive if you're getting your routine screenings and you're seeing your doctor on a regular basis. Because people wait till they have symptoms. That's why a lot of people wind up in emergency room. Most of the people in the emergency rooms don't have emergencies. They have maybe an urgent situation, but most people go in there when they have a cold, a flu, a sprained ankle, and they don't know what to do. And they wonder why they have to wait so long because most emergency rooms are trying to save people's lives. And the majority of people that come in do not have life threatening illness. So I'll back off because I'm sure my other colleagues have something to say. And I know that Nikki's going to pull the plug in a minute.
Yeah, no, but one thing I just wanted to
We want
say
to say
was,
hey to Marsha Oliver.
go ahead.
No, go ahead, Carolyn.
Okay, I was just going to say one thing, simply also getting your blood pressure checked once a year. Hypertension, high blood pressure, they call it the silent killer because most people don't realize when your blood pressure is high. By the time you do have a symptom from it, then, it could be causing some serious damage to your body. So, even something as simple as that, seeing a primary care doctor, getting your blood pressure checked once a year. We have high rates of high blood pressure in our community. And, I'm sure, many of us have seen young people who go for long periods of time, years and years, without knowing that they have high blood pressure, and untreated high blood pressure over time can lead to things like congestive heart failure and things like that that are very serious conditions. And we don't want to see young people, suffer from those things unnecessarily.
Yeah, I just following up real quick by saying this. There is
Absolutely.
no
Want to say
symptom.
hey to
There, there is no symptom for almost any disease in its earliest stage.
Stage.
Know that. Just because you feel okay, don't mean you are okay. So don't guess, get a test.
Thank you.
I
Thank
heard that, Dr. Mason. We want to say hey to Marshall Oliver. He says hello and congratulations. Carmen Pitts is here and she says good evening to all. Pamela Dominguez is here and she says, please define a safety net hospital. I think we did that earlier, but I know we will ask Taysa to give us the 30-second elevator pitch about what a safety net hospital is. Also, Carmen Pitts is here and she says, can you repeat that website for us, please? So, Taysa, if you don't mind, give us the 30-second elevator pitch in reference to a safety net hospital, and can you repeat that website?
Sure. A safety net hospital is, by definition, technical definition, a hospital that serves a patient base that is 40% or higher of Medicaid inpatient utilization, by definition. So we serve a high Medicaid insurance population. The website is savethesafetynet.org. It is a collaboration of all safety nets, talking about the importance of safety net and doing the advocacy and what we need to do to advocate for safety net hospitals at the state level.
Okay, with that being said, I see we've been blessed by Pastor Fields, who is here with us on today. Thank you, Pastor Fields, for being here with us. We were talking about saving our safety net hospitals and what happens if our safety net hospitals go away. Pamela Dominguez is here and she says thank you. She thanks you so much, Taysa, for sharing that information with us. Now, I know you guys hate when I say this. I know you hate it, but it's our time. So we're going to go around and we're going to ask, what's your until next Monday? And I'm going to start with Doug, my colleague who leads me and has fun in the sun. It's a little chilly in Chicago today, Doug.
Yeah, and it's overcast here, Nikki. It's not that much better. I just want to share the perspective that those safety net hospitals have an essential role to play in providing health care. And clearly, when you watch television, you drive down the road, you see the advertisements for the successful for profit hospitals. They have the money to do that. But that doesn't necessarily mean that they distribute their care equally. And so there really are holes in our healthcare delivery system. And from my perspective, it's essential that we maintain the financial viability of safety net hospitals so that
Absolutely.
everyone can have access to care.
Absolutely.
Outstanding. 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 Doug says, let's fill those holes. Well, Dr. Mason, you're until next Monday.
Well, thank you for everybody that was on the panel. I think it's great for people to understand the role that safety net hospitals play and also the federally qualified health centers can play. But the main thing is that you are the chief guardian of your health. And unfortunately, you shouldn't wait till you have a symptom because there's usually no symptom for any disease in its earliest, most modifiable state. So don't guess, get a test, get your blood pressure, as we just heard, get your basic lab works done, and see your primary care doctor at least once a year or more if it's necessary.
Outstanding. And thank you so very, very much. Well, Joe, you're until next Monday. That's the art connoisseur, the guy with all the great art.
Yeah, I'm going to simply say an ounce of prevention is worth a pound of cure. What you don't know can kill you. You are in control. You just have to make better decisions moving forward. And you can play a role in saving the safety nets.
Outstanding, outstanding. Well, Carolyn, you're until next Monday. What do you want the viewers to remember until next Monday?
So I would say get to know your safety net hospitals in the areas that you live in. Consider utilizing the services, especially for maybe tests and studies that you might need, such as your mammogram that you might need every year, or routine blood tests. And you know, their safety net hospitals help to increase your access to care, and we're here for you. And we want to build healthier communities. And we look forward to seeing you sometime at one of our facilities.
Absolutely.
All right, thank you so very much. Well, Taysa, you're until next Monday.
Well, I want to quantify one thing. I know we talked about Epic, the EHR system. So the AI that's built into Epic really allows hospitals to capture charges and diagnosis better because of how it prompts physicians to document. So it's not a bad thing. However, we do have to err on the side of caution because a lot of the data that is being used some of it is potentially biased. And so we need to err on the side of the caution as far as diagnosis, and make sure that our providers are doing their due diligence and listening to our issues and our needs and any healthcare challenges that we talk about. Second, I know last time we talked, there was a doctor that needed an MRI. If that doctor hasn't got their MRI, please call me because we can get you in tomorrow. And then third, I want to say, echo what Carolyn said, and Dr. Mason and Joe and Dr. Graham is, get to the doctor. Do not wait. Trust your local safety net. We provide awesome, amazing care by an awesome and amazing team. We want our communities to be healthy. We deserve to live longer and healthier lives. So thank you.
Outstanding, outstanding. Well, Caleb, my colleague, you're until next Monday. What do you want the viewers to remember until next Monday?
Well, I'd like for them to remember what Carolyn Tessa said about the difference between safety net hospitals compared to other hospitals. I remember years ago, I had some high hospital officials into our office from different states, and they stated that their model was 1/3 Medicare, 1/3 Medicaid, and 1/3 private dollars. And they wanted to base their operation, their going concern, on that formula. And it's hard because many of our safety net hospitals have 50, 60, and 70% Medicaid. And so if you don't have private dollars being filtered into the institutions, then therefore it's always a struggle for our safety net hospitals because many of them are giving charitable care. And so to be a going concern, they need funding. And so therefore, it's always wise to patronize our disproportionate share hospitals. Thank you.
Thank you, Caleb.
You're welcome.
Thank you, Caleb, so much. Well, Pastor Seyfields, you're until next Monday.
Hello, everyone. Thank you so much. I'll say this about the subject of safety net hospitals to sort of put a spiritual context to it. I lift up Jeremiah 30:17, where the Lord said, "For I will restore health to you and heal you of your wounds, says the Lord, because they called you an outcast." And that last phrase there says, because they called you an outcast. God responds to the marginalized, the poor, the less fortunate, and the least of those among us. And from our conversation today, safety nets do just that. They're an expression of care and compassion for those who may not have the wherewithal for proper medical care and getting medical help, things that they need. And so there's a need for it. And I think there's a biblical mandate for it, because if God responds to the outcast and marginalized, amen, and those who are poor, then we as a people in society have to have that same compassion for those who are least among us. And I close with it. The Lord said, as you have done it to the least of these, you've done it unto me. And I think safety net hospitals provide that type of compassion and care that we need as a human civil society to help our fellow brothers and sisters.
Mm.
Amen.
Amen.
Awesome. Well, Pastor Si, I don't want you to wake up Bishop Terry Mason, because he'll come back with a sermon for us on this.
That's right. We gonna wake them
Bishop
up. That's
Dr.
right. We gonna...
Terry Mason. Bishop Dr. Terry Mason. Well, I usually don't have it until next Monday. Usually I just say thanks for showing up and I'll talk to you next Monday. But tonight I have one. I was thinking about a poem that the congressman usually talks about all the time. It's a very simple poem. It said, "Life is just a minute, only seconds in it. Forced upon us, can't refuse it. Didn't seek it, didn't choose it. But it's up to us how we use it. You suffer if you lose it. You give account if you abuse it. Just a tiny little minute. Eternity is in it. And it's only 60 seconds in it." Well, we can't take Monday into Tuesday, nor can we take Tuesday into Wednesday or Wednesday into Thursday, and so forth and so on. There are 86,400 seconds in one day. Let's use those 86,400 seconds to make a difference in doing good. Who knows whenever one of us will have to walk into a safety net hospital. All hospitals are just that. They're here for the greater health of us. So let's use those 86,400 seconds that we have, because I'm going to use mine to do good. So let's use those 86,400 seconds in each day to stay positive and do something good. I promise you, if we use that frame of thinking, we could change the world. Thank you guys, and have a great one.
Thank you. Good night,
Everybody,
everyone.
take
Good
care.
night.
Bye-bye.
Thanks. Have a good night.